Oh, thank you both. I think that we have quite a few questions, and I'm glad that we do have plenty of time to answer some of those questions as well. So let me start off. Can the bladder tolerate BCG mitomycin treatment indefinitely, or what other methods could or should be used?
Well, happy to answer that question. So I haven't seen any data on how long you can tolerate BCG. Most people don't recommend it. If you, after 2 or 3 years, if you've had a very good response and no recurrences, we usually will stop the intravesical therapies and monitor you. In fact, if you recur more than a year after you got BCG, we can restart the BCG, and most people think you have nearly the same benefit. But it's not currently recommended to do more than 2 to 3 years of BCG, just because there's no trial that has really ever looked at doing it for much longer than that. There's really no reason to think that it causes any harm to the bladder, but it certainly can cause irritative symptoms. And so if there's no demonstrated benefit, why would you continue to do it, since you could always resume it later if you were fortunate enough to be disease-free for a long time.
Can I just add that in most of the series using all different types of intravesical treatment, there's been about a 10% chance of bad bladder symptoms after initial treatment or multiple treatments. And so every once in a while, there's a patient who really has a lot of bladder irritation or small bladder capacity. And fortunately, it doesn't happen very often, but that's one reason we don't just give these drugs to everybody. If we don't think it's necessary, we don't want to take that risk.
Mm-hmm. Okay. Another quick question, sort of following up with that one. What is the definition of BCG failure? When the BCG fails the patient, how do you define that?
Yair, you want to do that?
Just a recurrence?
Absolutely. So this is an area that even is a little confusing for urologists at times, because there are a lot of different definitions. So there is a condition where you had cancer, we give you 6 weeks of BCG, and at 3 months we look and you still have cancer. And those patients are considered BCG refractory, but we know that for about 30 to 40% of those patients, if we give additional BCG, they will have a good response at 6 months. And so unless you show signs of progression, where your cancer got worse or you have invasion of the lamina propria or a lot of disease, we typically will give people additional BCG. However, if at 6 months you've had 6 treatments plus 3 treatments, or maybe you didn't get all 6 or all 3, but you got close, maybe 5 and 2, and at 6 months you still have carcinoma in situ or recurrent bladder cancer, you're considered BCG unresponsive. And that's an important time point, because if at 6 months after BCG you still have disease, you're unlikely to respond for more BCG, and you should change your treatment. So 6 months is really sort of a critical time point for most of us in deciding, is BCG working for you or not? Because if it's not, there's no reason to waste more time. You really should either have your bladder removed or go on a clinical trial or try another therapy, because giving more BCG is almost never going to help you.
Okay, so there's another follow-up question that kind of follows on this one. The urologist would like to withhold BCG in the case of recurrence. She thought it'd be more effective as opposed to having BCG every 2 years following 5 years of being cancer-free, which is Dr. Lamb's protocol. What do you think about that?
I can comment on that. Dr. Lamb has a theory that we should keep doing BCG in patients who have responded, and basically doing it sort of infrequently, but do it forever. And so far, that's not really been tested in any kind of clinical trial. So it's, Dr. Lamb is a pioneer in BCG treatment, but those things really need to be tested before they're set out as a standard. So most urologists, I don't think, have adopted that approach.
Okay, thank you. We did have one question. Somebody had asked something about disclosures, and you are both very, very engaged and involved in a lot of research. Would you mind just doing a quick, brief disclosure on anything that you are working on that might be related to our talk tonight?
I will tell you that I do occasionally do work with the cisview people that that do blue light. I don't have a formal relationship with them, and I've never gotten any money from them, but I've worked with them some. And I have worked on one of the clinical trials that Dr. Lotan mentioned, which is with Genentech's checkpoint inhibitor, using that for BCG unresponsive bladder cancer. And I finally did a course with a company called Olympus that makes another scope, where we did a course teaching young urologists how to resect bladder tumors. And I was paid for that.
Thank
Dr.
you.
Lotan, do you want to do your disclosures?
Yeah, we may have to add it to your site. I think I work with doing research with about 4 different urine marker companies. I've done research with Abbott, Pacific Edge, CFID, MDX Health. So this is research on looking at urine markers to help detect bladder cancer. And some of them are in hematuria. I've also consulted for 2 of those companies in how to design trials and some of the health economics involved with that. I was involved with Photocure on the phase 3 trial for the flexible blue light, and I've consulted them on some health economic type issues. Trying to think if those are probably my relevant bladder things. I work with Genome DX, which are on more advanced disease, looking at tissue markers. And then I've worked also on metastatic disease, some trial design with AstraZeneca and Merck for checkpoint inhibitors, but not specifically for non-invasive disease.
Thank you both.
Yeah.
Yes. Well, you are both doing cutting edge work, and I think it's really exciting. We're really thrilled that you were able to present this today. There's another question, sort of switches gears just a little bit. Is there any place for radiation or chemotherapy, or radiation and chemotherapy in treating muscle invasive disease?
I would say mostly no. There's one of the clinical trials that's currently being developed is actually using radiation to make the checkpoint inhibitor work better, basically to kind of irritate the immune system to get the checkpoint inhibitor to be able to work. I think there was also a recent clinical trial with patients with lamina propria invasion, so T1 disease, using radiation, but that's not considered standard of care at this point. That trial has been completed, but there's no results yet. So I think I would say generally no, unless there's a very unique situation where that would be the approach. We don't generally use systemic chemotherapy for that disease either.
I think the implication was systemic chemotherapy and not local chemotherapy, which we discussed.
Right.
Thank you. Can you just do a quick definition of what the checkpoint inhibitors are all about? Because I think people heard you say them, but they were looking for an answer. What is a checkpoint inhibitor?
Go ahead, Yair.
Sure. We know that the way cancers trick the immune system is that they show them certain antigens, which are like flags on cells that tell the immune system, hey, we're part of the body, don't attack us. And this is a way that cancer cells use to mask themselves so the immune system, which is supposed to get rid of cells that are abnormal, as well as bacteria and viruses and other things that are attacking us, the immune system is unable to fight the cancer because the cancer is basically hiding in plain sight. the checkpoint inhibitors are basically ways to unmask the immune system because unmask the cancer from the immune system, and because they basically block these flags or these antigens that the cancer is trying to show the immune system. So the immune system now doesn't see this friendly flag and says, oh, now I can see that you're an abnormal cell and I'm going to fight you. And so this has been a very successful treatment for metastatic disease. For example, in melanoma, it works in some of the combinations work more than half the patients when previously we had no treatment. It's being used in almost every cancer now. It's being tested, but certain cancers like kidney cancers, which are very immunoresponsive, it's been successful. In bladder cancer, it's approved. Its success rate's kind of in the 20 to 25% rate for patients with metastatic disease. That disease spread throughout the body. There's a variety of trials being done in non-muscle invasive disease, and there was one trial that was presented at the meeting that suggested about a third of patients had a response at 3 months, which I'd have to say is not overly encouraging. Because the FDA requires that you have at least a 30% response at a year, and you can only assume that some of those 30% that responded at 3 months might have a recurrence between 3 months and a year. So it's still very early in assessing these agents, and some of them might be very important in combination, but that's what we're talking about.
Okay, thank you. So when treatment and surveillance protocol vary from hospital to hospital, how does the typical patient find statistics on what the best protocol is, and when should they ask for a second opinion about their treatment?
So even though there's some variation from doctor to doctor, there now are guidelines that are written by the American Urologic Association and by the European Urology Association. Those are available for anybody to look up. You can go to auanet.org and look for guidelines, and they're in there. And I help work on those, and so I think they're pretty good. I think it's fair to always ask your doctor if they're not following the guidelines, why they're not. And I don't think anybody should ever be afraid to ask for a second opinion if you don't feel like you're getting the answers that you want from your doctor.
Great. So you both as doctors don't ever feel offended if somebody is going to ask for a second opinion, do you?
I don't.
Dr. Lotan?
For us to be offended because we're seeing patients all the time for second opinions. But I would say the same thing. If your doctor is very sensitive, then maybe you need a new doctor anyway, because I think most urologists in America are so busy anyway because there's a lot of, patients that they're not going to feel offended or, if you want to get another opinion, in fact, you'll either confirm their judgment or maybe they'll learn something as well. But I certainly haven't had any qualms about sending my patients for another opinion if they were hesitant about what I recommended, because if they didn't like what I had to say, I didn't think they were going to be very compliant with my recommendations anyway. They might as well see if they can find an opinion that they would follow more likely.
Yeah, and often when I talk to patients about a second opinion, I often let them know that sometimes it will be a confirmation that you're doing the right thing with your doctor. So it's also a good thing about that. So there were a couple of questions for people. I know you mentioned smoking earlier, and there were a few people that said they've never smoked. Some people mentioned that they might have been exposed to aromatic amines in their careers. Can you talk a little bit about some of the influence of these other exposures on recurrence?
Most of that has not really been tested. I think for smoking, I showed that one slide that showed that if you quit, you could actually reduce your risk of recurrence. We think for bladder cancer that what causes the cancer could have been something that happened 20 or 30 years before. And we know that from smoking, that a lot of patients have a history of smoking but quit many years ago and still are at increased risk. So it's probably a very long process to go from the insult until the cancer cell actually starts to develop. But, for example, there was a lot of press about hair dye, and that patients that, particularly hairdressers who used a lot of hair dye on their skin, would be at increased risk. And that, I think, since then has actually been debunked largely, so that I don't think patients have to go around with gray hair necessarily who have bladder cancer. But many of the other things are really mysterious. I mean, we know that there's plenty of people that never smoked who get bladder cancer. And in fact, in women, it's as high as half of women never smoked and still get bladder cancer. So there's a lot we don't know about those environmental causes.
Right. And if you go to www.bcan.org and look on our Patient Insight webinars, we did one a couple of months ago that was specifically focused on the environmental risk factors and bladder cancer. So it went beyond smoking, although they talked about that. And it featured some experts from the National Cancer Institute that have been studying bladder cancer and the environmental exposures for many, many years. So I would invite you to go take a look at that. There's another question that I think is really interesting. I was wondering if age affects treatment approach. Are you more or less aggressive when you have a 30-year-old with a T1 high grade and CIS, for example?
Well, it certainly affects it. Thank God we don't have too many 30-year-olds with bladder cancer. But I think that I think of age a little differently. I think of life expectancy as the more important parameter, because if you have a patient who has a relatively short life expectancy, you're really thinking about recurrence and progression a little differently, because they may not have very much time for a cancer to really do something very bad in terms of progression. Let's say you have a patient in his mid-50s with a 30-year life expectancy. If they didn't have bladder cancer, I might be more aggressive in terms of treatment, because I'm starting to think, will I be able to keep them disease-free for 30 years? It becomes something in the back of my mind, especially if they're not responding to initial treatments. I'm asking myself, why did they get cancer so young? And should I just take out their bladder sooner rather than wait and do every single treatment in my armamentarium, with a concern that if I'm wrong, they've lost a lot of potential life expectancy. If you have a patient in their late 80s, you certainly are not going to be as aggressive. The only other caveat I would say is that, unfortunately, there are some studies that suggest that BCG as an immune therapy does not work as well in octogenarians. And maybe it's because their immune system is not quite as robust. And so in some of those cases, I might consider, especially for intermediate risk patients, I'll favor chemotherapy rather than BCG as my first line therapy, with a thought that maybe they'll have less risk of infection, and maybe the BCG is not going to be that much better than chemotherapy in those patients.
Okay, excellent. Thank you. Dr. Lotan, you talked a little bit about some of the potential side effects from BCG, both the treatment and the maintenance BCG, and how your body reacts to them. And one of the questions that came in was, is there any significance to having no side effects at all after induction BCG and maintenance BCG?
I think it's a very good question. I think a lot of people used to think that if you had more reaction, you'd have a better response, and it seems to make sense. It says, well, your immune system came and you had a lot of inflammation, and hence you have a good response. But I haven't seen very good data to support that. In fact, I've had plenty of patients who've had almost no side effects and very good responses. So I think the jury's out on that. And I don't know, Eila, if you've seen any reports on that.
No, I agree. I think it's, when patients get a bad reaction, we tell them it's good news, because it means they're reacting to the BCG. But I don't think you can say that the converse is true.
Okay, well, thank you. I guess then that patient might just consider themselves lucky and have to wait for that next surveillance, correct?
Yes.
Okay. Um, what are the statistics for recurrence of cancer for patients who've had a radical cystectomy?
So the best predictor for recurrence is actually how extensive the cancer was at the time of surgery, so what we call the pathologic stage. So for example, the kinds of patients we've been talking about today who have non-muscle invasive cancer, say somebody has carcinoma in situ and BCG has not worked and they're going to go to cystectomy, if they have carcinoma in situ on their final pathology and the lymph nodes are negative, then their cure rate is very, very high, probably close to 90%. Never quite gets to 100%, but it's very good. They occasionally will get recurrences in the ureter or the collecting system or the urethra, but generally not. On the other hand, if somebody who has even non-muscle invasive disease at the time of surgery has positive lymph nodes, then we know our cure rate is down around 30%. And then we'll generally talk about using chemotherapy or other treatments in addition to surgery to try to improve on that. So it's, we're always trying to guess the exact right time point to do a cystectomy so we don't wait so long that the cancer's in the lymph nodes, but we don't necessarily pull the trigger too early when we still might be able to treat the patient with intravesical therapy.
Okay, give me one more second. Is a high-grade TA with 5 to 10% high-grade cells considered intermediate or high risk, and what should they be doing?
So you're talking about somebody who has low grade with focal high grade primarily. Technically speaking, any high grade, they're at a minimum intermediate risk.
Right. So we would generally recommend intravesical therapy for that patient.
Okay, well, we're winding down, probably have time for one more question. Let me just try to find one that's going to be a nice way to close this out. Sorry. A patient has CIS and they've been cancer-free for the past 3 years, although the last 3 urine cytologies showed suspicious cells for high-grade TCC-CIS. No treatment was administered. The doc says he can't treat it unless it's a confirmed cancer. What should they be doing? What should they be asking their doctor?
I think the question is what kind of evaluation did they have? Because carcinoma in situ is notorious that it can go to different parts of the urinary tract. So for high-risk patients in general, we recommend upper tract imaging, like a CT urogram or MR urogram or retrograde pyelograms once a year. I would be concerned, are they missing cancer cells somewhere else in the urinary tract? And the other place it can hide if it's a man is a prostatic urethra. If it was me, I would do blue light cystoscopy, biopsy the prostatic urethra, and then also evaluate the upper tract, because suspicious for cancer cells is mostly a positive type finding, and you worry that there might be cancer cells somewhere else in the urinary tract. I would say that if it was persistent, I would even consider whether or not to go back on BCG therapy, because the upside may be higher than the downside, because if I was really concerned that they might have cancer, most likely it still would be in the bladder. If they had BCG before, resuming BCG really is not a high risk proposition, and it certainly might make everybody feel a little bit better about the situation, even though it would be nice to know where it's located before I started any treatment.
Okay. Well, thank you both so much for doing this. We took this picture at the Society of Urologic Oncology meeting, and I thought it was a nice way to close down tonight's presentation. So Dr. Lotan and Dr. Skinner, thank you so much for sharing your knowledge and time with us this evening. I really do appreciate it.
Happy to be part of this, and I apologize again for being late.
Well, you were taking care of a patient, so that's okay. So that's a good excuse. So once again, I'd like to thank EMD Serono Pfizer Partnership, Genentech, Ferring, Photocure, Merck, and Insight for making this Patient Insight webinar series possible. Please remember that you will receive an email with a link to the short evaluation. Please do take a few moments to complete these questions. They're very short, and give us some feedback. Your opinion is very important to us, and I will be sharing it with our presenters. And you will also be getting a link to the recording of the program as soon as it's processed. So thank you all so much for joining us tonight. And we will answer some of these questions. We do have a lot of other webinar programs and resources on our website, and I will work tomorrow with our education manager to help steer you in the right direction to answer some of the questions specific to BCG, other questions specific to risk factors, and then there were others that were specific to diet and exercise. So we'll get all that information out to you tomorrow. Thank you so much for joining us.
Have a good night.
Good night.
Good night, everybody.